thank you again for giving this talk. It was actually based on a talk that I give at the World Congress with the idea, or we are treating many of our patients now with biologics, and we sort of started off now continuing using these drugs, and the question is whether we can stop the biologics as well. I'll focus on reasons for stopping, and in the end I'll come back to if maybe we should not stop always, or we cannot stop always. So my disclosures again, I must say that I usually critically appraise all the literature, but for this talk I could not do that intensely in all the studies that I used. Well, we know psoriasis is a lifelong disease. There's no cure. Patients may have multiple comorbidities, and it has a relevant and cumulative impact on patients. So they need lifelong treatment, inducing remission and reducing the impact. But we have concerns about side effects and effectiveness and the convenience of all those treatments. So sometimes patients have low expectations about the treatment, there's poor compliance, and then we have poor clinical outcome again. So we need a patient-oriented care, and Joe Lambert already mentioned that. We need to incorporate the patients, and we need to do shared decision-making and reaching the patient's needs and goals. But patients want to keep complete clearance, or almost complete clearance. So we know about the old treatment goals. We have learned today about the new Spanish treatment goals that will be used probably in the future. So the PASI 90 instead of the PASI 75. We've seen this diagram already, which is from my group. We have to take into account all the different aspects when we are treating our patients. And I'm now thinking of the patients that are treated with the biologics for psoriasis. Every time we see them for monitoring, we need to look at the different aspects of the patient, the disease, the treatment aspect, and hopefully in the future more predictors for success and failure. So we have many treatments available, and we should still try to combine as much as possible and try to reduce as much as possible. And in the past, when I was trained, it was inducing remission. And after you had induced remission, you stopped the treatment. It was like, for example, 16 weeks of methotrexate, and after you had a PASI 90, you would stop the treatment and see how long the remission would last, and you would, if there was a relapse, you would restart again. Then we started off with more rotational therapies when more treatments became available. Then we did more sequential therapy. After a certain period of methotrexate, for example, we could initiate intensive topical and maybe restart with UV or another systemic treatment. We started off doing combination therapy, and now we are in the era of prolonged monotherapy with these biologics. So it's just good to think about it in that way, how did it went historically. So stopping or continuing biologic treatment in patients achieving a complete remission is debated. There are people that are pro continuing treatment, and there are people against continuing treatment. So when is stopping biologic treatment recommended, and could are there other solutions to keep on achieving complete remission, like dose reduction based on therapeutic drug monitoring, or combining and in that way reducing the use of biologics. So, but first, can we stop biologic? And I looked through the literature to find ways, because we are increasing the use of biologics more and more. In the past, we did like 50% classic conventional therapies versus 50% biologics, and we're moving to 20 and 80%. And of course, this is from one group, from the bioderm group, the Spanish group again. And the costs are increasing, as we all know. This is a survey done in the US, and it mentions that for the patients treated with the biologics, pointer is not working, it's the highest amount of cost yearly. And it goes up and up. And here you see the differentiations between inpatient care and the cost for that, which goes down, the outpatient medical cost, and the outpatient pharmacy cost. and it goes up for the biologics especially. So rotational therapy, as I mentioned, is a possibility, and maybe we should start doing that also with the biologics. As we know, there are breaks anyway for certain reasons in biologic therapy, so why not doing that more often? For example, if you go on holiday anyway and you have very good effect of seasonal effects on the sun and ocean vacations, it could be a reason to stop for a while the biologic treatment. If you need live vaccinations, live inactivated vaccinations, you need to stop sometimes, and maybe you could see whether you could stop for a while. With pregnancy, we need sometimes a break because not all the biologics can be combined with pregnancy yet. Also, you could stop when certain triggers are gone. For example, there's less stress in your life. The other triggers like medication or very obvious dental problems are gone. Maybe that's a reason the psoriasis is not so severe anymore and you could stop. We could make topical treatment for those patients who have not so much psoriasis anymore very attractive, and maybe we should work on that as well, because many patients have the idea, or it's still only sticky, ugly topical treatments, but we can make it more attractive in sort of a spa kind of environment and in nice daycare centers. Looking at the data differently, I looked to non-adherence, and it seems, and this is data from rheumatoid diseases, that patients are not so compliant with the biologic as we think they are, also not with the conventional systemics, and knowing that 25%, so 1 out of 4 patients is not complying with their biologic, it means that they're not using it, so it might not need to continue constantly the biologics and keep them on the biologics all the time. So it's helpful information. I think we should do this research also for dermatology and for psoriasis. Another reason to sometimes say, well, maybe we should discontinue biologic is because of the adverse events. We have a lot of information about the adverse events. We did systematic review of all the adverse events of etretinate by the time, and there are so many adverse events still from these biologic. We should not ignore them. It could be a reason to stop your biologic. We know specific side effects like the cardiovascular events, the malignancies and serious infections, and we know from the anti-IL-17s the exacerbations and causes of inflammatory bowel diseases. Another report about that, the same, irritable bowel disease, candida infections, and tuberculosis on certolizumab, and also psychiatric events, for example, with apremilast, with depression as an example. So adverse events could be a real reason to stop, also because of the frequent upper respiratory infections or injection site reactions. The idea always for stopping biologics is that you have a relapse, a rapid relapse. But looking into these data, we can see that the relapse follow-up of 9 months, the median time to relapse of 1.5 months, but it could last for nearly a year until the psoriasis relapses. You could stay out of being treated with biologics maybe for half a year without having a severe relapse. And the patients that do relapse, they restarted, part of them on topicals, part of them on conventionals, some on biologics again, but part of the patients could be initiated with another treatment. And this diagram shows the time to relapse of these 77 patients in this study. And it's moving to another way of looking at the data. Sometimes you may be able to stop. Also, the data on drug survival shows us that many patients fail on a biologic treatment anyway within around a year or 3/4 of a year. So after failure, you could reinitiate a biologic, you could think of other treatments in the meantime. And let's look at lessons from rheumatology and gastroenterology. So gastroenterology looked into relapse rates and predictors for relapse in real-life cohort of IBD patients. They looked into the patients receiving infliximab and adalimumab who discontinued their treatment, and they tried to find predictors for relapse. And in this diagram you see that our patients with Crohn's disease and colitis ulcerosa, part of them relapsed, part did not relapse, so treatment did not need to restart. And it's about 50% in Crohn's disease and 1 out of 4 in the colitis ulcerosa. And they looked at all different aspects if they could see which patients would relapse and which patient not. And they combined data of baseline demographics, clinical data, and they tried to invent a prediction model. This is published in a poster, and they sort of have this prediction model now, and it helps you selecting patients who could stop the biologic and who could be better continue with the treatments. These studies are also done in Crohn's disease, but data are not published yet. So moving back to psoriasis, we know that the costs are rising for biologics, so we need to do something probably. Some issue could be that we move on to biosimilars, that could lower the costs, but we know that physicians are still very hesitating for non-medical reasons to switch to biologics, so we might need to improve that. Another way is to taper down the dose, and therapeutic drug monitoring is one option. We want to get rid of the one dose fits all, and we have mentioned already the therapeutic range for adalimumab. So if you have a too high trough level of your adalimumab, please taper the dose. We are also looking in combination treatments and see whether that could lower the dose. We have performed a study, multi-center study, trying to improve adalimumab treatment, because we know that 1/3 of the patients fail on adalimumab treatment, and by combining it with methotrexate, it might improve drug survival of adalimumab, but it also might we will be able to taper the dose. So here you can see that the blood trough levels of adalimumab plus methotrexate are higher than in the mono adalimumab group. Tight controlled dose reduction in biologics is now studied in the Netherlands as well. We looked at the data of rheumatoid arthritis and trying to do that in psoriasis as well. Another reason not to stop biologic is that retreatment might fail, but there are studies that is not the case. After secondary loss of efficacy, patients would stop and be treated with something else and restart on the same biologic, and this study shows that it might help. Another reason not to stop your biologic and infliximab is because of increased risk of infusion reactions. If you not stop more than 4 months, it should not be a problem. And the other thing is that you could prevent infusion site reactions or infusion reactions by giving pre-treatment once or twice for the next infusions, and that will not be the problem then. So can biologic ever be stopped? Yes, maybe we should do more on rotational therapy, take into account the whole life circle. There are reasons to stop anyway. Sometimes there could be safety reasons. Maybe there's poor compliance anyway, and we could learn from all the lessons from rheumatology and IBD. So some patients who are chased with all these infections or injections for biologics want without injections. We have a good consensus report on appropriate treatment optimization and transitioning in the management of psoriasis from Roich et al. And here is also reasons why we can pause treatment, and it's summarized very clearly in this paper. I'm going to move on. Yes, thank you for your attention.